Sadanand, we are live.
Thank you, Rachana. Good morning, everyone. I am Sadanand Mankikar. It gives me great pleasure in welcoming you all to this health awareness program organized by Sringeri Vidya Bharati Foundation and Ontario Konkani Association. Today's focus is on arthritis and osteoporosis. One affecting the joints, the other one affecting the bones. We are extremely fortunate in having two experts from our own community to educate us on these two diseases. Our first speaker, Dr. Sahil Koppikar from Ontario Konkani Community, graduated from Queen's University Medical School and completed his residency in internal medicine from Queen's University and in rheumatology from University of Toronto. Currently, he is a rheumatologist at the Women's College Hospital in Toronto and assistant professor in medicine in University of Toronto. In addition, he is directing a unique multidisciplinary clinic in Timmins, Ontario. Today, he will educate us on the categories of arthritis, how to diagnose them, how to prevent them, and how to manage them. Dr. Koppikar, the floor is yours.
Thank you, Sadanand ma'am. I'm just going to share my screen here. You can see my screen, okay? The slides?
Sure, yeah.
Okay, perfect. Good morning, everyone. Thank you for having us this morning. Thanks to OKA and SVBF as well. Just before I get started, I wanted to apologize. I'm just getting over a cold, so if my voice breaks or if I take a sip of water, I'm sorry about that. So I'll be talking about arthritis. As Sadanand said, I'm a rheumatologist at Women's College Hospital and at University of Toronto, an assistant professor. I have no relevant disclosures for this topic, but just a few disclaimers since I'm the first one going. So any information that I or Dr. Gakhal later talk about is not exhaustive just due to time restrictions this morning. We do not represent University of Toronto or Women's College Hospital in any content that's presented here, and it's our own advice. And if there are any errors, hopefully there's no errors, but if there are, then it is not representative of UFT or the Women's College. And none of the advice or information presented today is meant as individual advice. So if you're concerned about any of these conditions, please speak to your healthcare providers for a diagnosis and treatment plan. So just over the next 25 minutes, focusing on arthritis, I'll start off by overviewing the different types, just so you can place how big this field is. And then, well, for most of the talk, we'll be focusing on osteoarthritis. And osteoarthritis is the most common type of arthritis. So we'll talk about what it is, who gets it, and importantly, how to prevent or manage it. And I've tried to make it practical based on a lot of the questions that we get from patients around it. But if we don't answer anything that you have burning questions about, there is a chat on Zoom as well as on the YouTube link. And we will be sharing our slides at the end. So all of this will be available. So why don't we get started? So one of the things I wanted to start about was about arthritis myths. So there's so many things that we hear from patients, from family friends about arthritis that are read on blogs, on TV, on the internet. And a lot of it is not necessarily true. Things like arthritis is an old person's condition or an elderly person's condition, that it's a normal part of aging, that it's not serious and nothing can be done about it. Or on the other end, a lot of bogus recommendations about what should be done about it from a lot of providers. And there's not a lot of support for a lot of these comments. So hopefully after today, you'll see why these are myths or why we think these are myths. And I'll try to shed some light into what the reality is based on some evidence or studies that support the truth. So what is arthritis before we get into it? So arthritis is a general term that's used for any condition that affects the joint or the tissues around the joint. And there's more than 100 types of arthritis, actually. So arthritis is a category. It's not, a lot of people say I have arthritis, but there's many different types. all of them, if not most of them, can cause pain and stiffness around the structures involved. And one thing I wanted to clarify here is an old term called rheumatism. It's an old British term that is essentially an old term for arthritis and often confused for rheumatoid arthritis. So rheumatoid arthritis is a specific diagnosis, an immune arthritis, whereas rheumatism is an old term for just, I have arthritis in general. And it could be any of the 100 different types. Just in case a family member or you hear from any healthcare provider, this term, it just means arthritis in general. So as I mentioned, there's many different types of arthritis or causes of joint pain. The most common being osteoarthritis or degenerative arthritis is another term. You may have normally heard it being mentioned as wear and tear arthritis. What we deal with as rheumatologists most of the time is autoimmune arthritis. So things like rheumatoid arthritis, lupus, or other conditions called psoriatic arthritis or ankylosing spondylitis. And this is where the immune system targets the own joints and can cause inflammation. There's other arthritis called gout or pseudo-gout that you may have heard of. Injuries to the joint can obviously cause joint pain, but predispose to certain kinds of arthritis. And then many other causes that won't fit on the slide. So other medical conditions can cause joint pain and arthritis, infections of the joint, and so on. And why am I mentioning this? Is because often we hear, I have arthritis from a patient, but it's important to differentiate them because the diagnosis lends to the treatment and what we can offer to make someone feel better or to prevent these arthritis from coming on is important to differentiate because all of them to the individual will feel as joint pain or pain around the joint. But it's our job to differentiate it so that we can provide the right treatment because not all joint pain is treated the same way. For today, as I mentioned, we're going to be focusing on osteoarthritis, and we'll talk about what it is, what may indicate, what symptoms may indicate that you have it, and what we can do about it. So you may have heard it referred as OA, which is the short form for osteoarthritis, or degenerative arthritis, or degenerative disc disease if it affects the back, or even wear and tear arthritis. So different terms based on where it affects, based on which specialty is using the term. But osteoarthritis, one important point I wanted to make here, is different than osteoporosis. And these are commonly confused in something that we hear in clinic a lot. Osteoporosis is thinning of the bones that Dr. Gakhal will be talking about a little bit later. And osteoarthritis is actual arthritis and pain in the joints affecting the joint. So what is actually happening? What is osteoarthritis? So it's a little bit more complex than this, of course, but I've simplified it into really four steps. And it starts with cartilage breakdown within the actual joint for various reasons. So when the cartilage starts to break down, and we'll talk about some of the reasons later, the underlying bone starts to change, both structurally, the bone changes, as well as the tissues and the cells in the joint start to change. And that causes inflammation locally in that joint. These changes usually develop in osteoarthritis slowly and can get worse over time. The symptom that a person may feel because of these structural changes and local inflammation is pain, stiffness in the joint, occasionally swelling of the joint compared to the other side. And obviously it can cause limited function, ability to do things with that joint and disability in that area or throughout for that patient. So why do we care about OA, or why am I focusing on that mainly today? Well, because it's the most common joint disease in our population. 1 in 5 adults can have symptomatic osteoarthritis. Many more than this can have osteoarthritis happening in their joints, but about 1 in 5 adults are symptomatic from it. So likely many people on this call, osteoarthritis does affect them. This is Canadian data that shows the prevalence or the amount of osteoarthritis in our population. And you can see it starts, there's a prevalence in 40-year-olds as well, 30, 40-year-olds, but it starts to rise with age. And once you hit 70, 1 in 4 men and 1 in 3 women can have osteoarthritis affecting any one of their joints. This is CDC data that shows that in about 15, 20 years, so by 2040, 2045, osteoarthritis will become the most common chronic condition in high-income countries, in which Canada falls into. So if it's common, it's increasing. Why do we care? It's not your heart, it's not your lungs, it's not your kidneys, it's not your major organ, right? It's just the joints. We hear that a lot from friends, family members, patients. Well, it's important because yes, it can cause a lot of disability and functional problems in the joint, but also because osteoarthritis clusters and comes along with other serious chronic conditions. So there's really good evidence to show that osteoarthritis or patients with osteoarthritis have a higher risk of getting other conditions such as diabetes, high blood pressure and heart disease, strokes, and even things like dementia and higher risk of depression in those with osteoarthritis. And there's good studies to show the impact that this joint condition can have on the entire health of the patient. Just to highlight this, so this is by one of our colleagues in Toronto, actually looking at Canadian data, and she looked at individuals with hip or knee osteoarthritis that had difficulty walking because of the arthritis. Those patients, compared to the general population, had a 17% increased risk of heart attacks or strokes compared to those who didn't have osteoarthritis. And those same patients also had a 24% increased risk of getting diabetes and then complications from their diabetes. So hopefully you can see a little bit, there's a lot of other studies showing this, but you can see that it's not just the joint, that it can have an impact on the overall health of the patient. Why does this link exist? Well, it's probably complex and there's several factors, but you could probably clump it into these four reasons. So firstly, there's shared risk factors. So osteoarthritis increases as individuals get older, and so do these other medical conditions. But one of the common links is elevated BMI or body mass index or obesity. So elevated weight is a shared risk factor between heart disease, diabetes, as well as osteoarthritis. Medications that patients may take, anti-inflammatories, especially over-the-counter or prescription ones, sometimes aren't great if you have underlying heart conditions and can aggravate and increase the risk of heart attacks and stroke. There's inflammation in osteoarthritis in the joint, but in many other types of arthritis, this inflammation is quite a lot and can affect the full body and accelerate heart disease and stroke as well. So inflammation likely plays a role as part of this link. And another common link is physical inactivity, which can lead to osteoarthritis, but also once you get the arthritis, because of pain, a lot of patients may not be as active. And obviously that is strongly linked to heart disease and diabetes, or inactivity is linked to that. So far, we think there's several reasons for this link, for these links between the conditions. So I hope I've convinced you in this whirlwind first 5 minutes that osteoarthritis is very common. It's increasing in our population and will become one of the most common, if not the most common chronic condition in our society in the next decade. And it can be disabling at the individual joint level, individual patient level, but can also affect the entire health of the patient. So it's not just the joint, as we hear a lot. So how do you know if you have joint pain? So obviously you can't look into the joint, but it usually causes some classic symptoms in joints. So the most common symptom is pain when it becomes symptomatic. It's usually pain with use of the joint that gets better with rest. There may be tenderness or pain on palpating or pressing the joint. There may be associated stiffness, especially in the mornings, but this stiffness is usually less than 30 minutes. If the stiffness in the joint is more than 60 minutes or 2 hours, it may suggest an immune arthritis or other arthritis, and you should speak to your family doctor or your healthcare providers. Obviously, as a consequence of the arthritis, you can lose the flexibility in the joint. There can be grating sensation, bone spurs. The joint may give away or it may lock. So getting stuck, like for example, when you're going up and down stairs in the knee. Not everybody necessarily gets this, but these are some of the symptoms that can be associated. But usually it's pain, tenderness, and some stiffness in the joint, and pain with use of the joints. These symptoms can develop gradually, but other times it can come on suddenly as well. And symptoms can come and go, but also they can persist over time. So it's different in everybody. It's different based on the joints involved. So there's no one kind of package that a person may experience. And it may be different in different joints in different people, in the same person as well. The most common joints affected by osteoarthritis are usually the back, so the lower back and the neck. The knees and the hips are the most common by far. And then the base of the thumb, the base of the first toe, the big toe, and then the finger joints near the nails as well can often be affected by osteoarthritis. These are the most common, But of course, osteoarthritis can affect anywhere that a joint is present. So what causes it? So we've talked about what it is, why it's important in our opinion, but what causes it? Because that will lend to how to prevent it and how to manage it. So there's several joint level issues and several systemic or whole body level issues that can precipitate osteoarthritis. The biggest attention usually goes to joint injury. So if you've torn a ligament before, you've fractured a joint or injured a meniscus, so the structures within the joint have been injured previously, that can predispose to arthritis sooner rather than later. And then obesity or elevated weight plays a significant role, especially in hip, knee, and lower back arthritis. There's other systemic factors such as age, genetics, so family history, the sex, so women more than men, although men can certainly get it. And other medical conditions are more systemic factors that play a role. Obviously, we can't change our genetics or our sex or age, but there's other modifiable risk factors. And this is just a summary of the main ones that we talk about with patients. So I've already gone through all of them. So how do we diagnose? How does a clinician diagnose osteoarthritis? So the first important point here is that it's a clinical diagnosis, meaning there's no one test to diagnose it. So while x-rays and blood work can be helpful, they look normal early in the disease. So even if the tests look normal, you may still have osteoarthritis. So it's important when you go to a doctor with joint pain to have your story all together. When did it start? How bad is the pain? When does it hurt? When does it feel better? What have you tried to do to it? Are there any other associated symptoms with it? Which joints are involved? Because we really rely on 90% of it is the story to help differentiate the 100 different types of arthritis, or at least the various categories. Once the story and the physical examination is complete, we have an idea of what is going on, and then the test can be done to rule in or rule out other conditions if it's not very clear right from the start. So, and then once this diagnosis is made, an individual treatment strategy can be discussed with the patient because it's different based on the joint involved, based on your other medical conditions. So that's where the individualized treatment plan comes into play. But you may be wondering, okay, if I don't have joint symptoms or if I don't have osteoarthritis, how can I prevent it from coming on? So prevention of osteoarthritis really focuses on the risk factors that I was addressing before, or the modifiable risk factors. Like I said, we can't change our genetics, our sex, or our age, but we can certainly focus on the modifiable risk factors, of which the most important is weight management. So weight management or weight loss, if that is necessary, can significantly improve symptoms of arthritis, can reduce the reliance on painkillers, can prevent the actual progression of osteoarthritis, and can prevent progression to surgery. And there's good studies showing that. It's the hardest thing to do, but the one with the best evidence. Reaching or maintaining a healthy weight can take the pressure off the joints, can strengthen the muscles around the joints, and that's why there's less use of medications and less progression to surgery. Tightly linked to the weight management is physical activity. So usually Canadian recommendations are 30 minutes of moderate exercise per day. That's very hard to do for many people, especially if you're not doing anything right off the bat. But any activity is better than none. Usually from an arthritis perspective, we recommend moderate, low impact activities. So things like walking on a flat surface, a stationary bike may be helpful. And for those who enjoy swimming pools or aquafit, that can certainly be very helpful to prevent and as well as alleviate symptoms for those who have it. Regular physical activity also reduces the risk of developing other conditions linked to arthritis, such as heart disease and stroke. So in general, you'll see all of us recommending that for prevention in general. The one point we wanted to make here is that physical activity will not make arthritis worse. You may feel pain when you first start doing it, but you aren't damaging joints. Choose an activity that you enjoy. If that's just simple walking around the mall for 10 minutes, that's a start. But choose activities that are easy on the joints, like the ones I mentioned. These are low impact, low risk of injury to the joint, low risk of twisting anything, And you don't have to go to the gym. You can do simple things at home is what we tell patients. Because if you start for 5 to 10 minutes, in a few months, you can increase that to 15 and go up from there. And self-management classes can also be very helpful. So these are through your local providers, like a local YMCA or certain local classes, or also provincial organizations, which I'll go over a little bit later to give you resources. And this helps with education on what arthritis is, how to manage your symptoms, what's safe for you to do, when to seek attention from a doctor, similar to these seminars that you're attending today. So these are the three main pillars of prevention. So what we tell everyone is there's no magic wand. There's no easy answer, right? Like maintaining a healthy heart or preventing diabetes, it all comes down to taking an active role in your health. Exercise, diet have a significant role in preventing arthritis and its associated comorbidities, such as heart disease and diabetes. But unfortunately, if you were to go on to have symptoms from your arthritis or osteoarthritis, how do we manage it? So a lot of times we'll see other doctors or even patients say, oh, it's just a joint. There's nothing we can do about it, and just ignore it. That's probably not the right approach, because there is a lot of options available to reduce symptoms, improve your function, reduce the reliance on medications if you need medications, and procedures as well. Like most things in medicine, there's no cure. 95% of things in medicine don't have a cure. It's treatment based. Maybe one day we will have a cure for this, and that's our hope. But right now, it's the treatment and the goals of treatment are to reduce your pain, improve your function, so ability to do things with those joints, and reduce your need for medications, and try to reduce the risk of progressing to surgery for the few that need it. So we have a toolbox that we use for arthritis management, for osteoarthritis management. This is very different than what we do for immune arthritis or other kinds of arthritis. And really, it relies on 3 stages. For everyone, it's around the same categories as prevention. So weight control, exercise, I'll go into this a bit more detail. Then medications come into play, whether that's medications or procedures. And then lastly, surgery, which few people will go to, not everyone. And we're trying to prevent that progression through these first two stages. And this will look different again for every patient, and will look different based on the joints involved. So the first level is the non-medication treatments. And this is what we push, because it's always safer to do non-medication things rather than throw medications just to help someone feel better. So it goes back to the same prevention strategies: weight loss, weight management, and physical activity. When we talk about physical activity in terms of treatment, though, we talk about specifically strengthening exercises. So that's where a physiotherapist can become very helpful, because there's very specific strengthening exercises to strengthen the lean muscles, which can take the strain off the joints and can prevent worsening and progression of the symptoms, as well as progression of the disease itself. And there's good evidence to show that physiotherapy, the right type of physiotherapy, is better than any sort of medication and better than any other procedure that we can do. Physiotherapists, you don't have to keep going to them, but if you can learn in 1 or 2 sessions the strengthening exercises to do, then you can do them at home, and that's the most important. A lot of times they'll offer other things like ultrasound, the TENS machine. If you have coverage and you feel better, you can do that. But that's not where it will actually improve in the long term. It makes the clinics money, but they have to show you strengthening exercises in an active program, because that's what will actually help you in the long run. Where an occupational therapist can be helpful is with devices or splints or braces. What these devices do is they provide stability to the joints. They strengthen the structure that may have been lost because of the arthritis, and they improve the function of the joints. And an occupational therapist can help do that in general to help improve function, but also can help design devices such as splints for you that can do that for you as well if needed. So that's where physiotherapy and occupational therapy come into play in the first stage for those with symptomatic osteoarthritis. For those who can't do these things, such as activity, because there's too much pain, or despite doing these things, that's where the medications come into play. So medications can help relieve pain, if the initial steps don't help. And these can be right from creams, topical therapies at the first stage, to pills and injections as well. So over-the-counter things such as topical Voltaren, which is an anti-inflammatory, some people find it helpful. The vast majority not, but it's a safe thing to try, especially for superficial joints, such as those in your hands, like the base of the thumb or your digits. It may not work as well in the deeper joints, such as the hips or the knees or the back. And some people find a benefit, but it's relatively safe, so you can go ahead and try it. There's also compound creams, so a mixture of various medications that can be prescribed, whereas Voltaren's over the counter. Prescription compound creams can be given by doctors as well. Those are more expensive and usually reserved if you have insurance or are willing to pay for it. Then we get into more systemic medication. So over the counter is things such as acetaminophen, or also known as paracetamol in the rest of the world, which is Tylenol. And then anti-inflammatory, so non-steroid anti-inflammatories like Aleve over the counter, but there's also prescription ones, a whole host of prescription ones as well. The decision to use these, you should consult with your doctor, because some of them can interact with other medical issues, especially if you have heart disease or high blood pressure already. So what your maximum should be, whether you should use that, you should consult that with your doctor. There are prescription medications, a medication called Cymbalta. This won't put cartilage back and won't reverse the damage, but has shown to help significantly in studies as well as in real life for those with hip and knee arthritis. Usually we'll recommend it after the first stages. So if you've done physio, you've splinted, you've done the over-the-counter and the anti-inflammatories, or you can't use it because of your other medical conditions, then Cymbalta, which is a prescription medication, may be helpful in some cases. And then kind of at the top of that, concurrently with all of these things, is steroid injections, which based on the joint, your family doctor can do, or refer you to a specialist who can do certain injections, like in the hands or the feet. And these are for alleviating inflammation locally. The steroid injections can potentially help relieve pain for about 2 to 3 months on average, but some people get very prolonged relief and some people shorter than that as well. But it's safe relatively because it's local and it doesn't affect, in most cases, the full body, versus medications can affect the full body. So in the right person, a steroid injection may make sense as well. And the steroid injection can be used as well to alleviate pain, so that you can start doing physiotherapy, so that you can break that cycle of pain, so you can start doing the level 1 management and not become reliant on these medications in the long term. So steroid injections can be used in various ways to treat, to prevent pain, to reduce the pain so you can start the exercises, and so on. And at the last stage is really surgery for joint replacement, which a few people progress to. The goal is to prevent progression from a medical perspective, which is where we come in. And there's no maximum age for joint replacement surgery. It depends on your other medical issues as well. But even after surgery, even though they're mostly successful, what the surgeons will say is, to have a good outcome, you have to do exercises and strengthening of the muscles around the joint that they replaced. So at the end of the day, for prevention, for treatment, and even after surgery, strengthening exercises remains the cornerstone of this condition for managing it, even if we do other things around it. So what can help? So there's many local resources in our province that can help. So Arthritis Society Canada, and I'll put links to this a little bit later at the end of the presentation, and we can send it out. But Arthritis Society Canada is, if you haven't heard of it, is provincially funded, actually nationally funded, but we have it in every province. And they have education sessions similar to this. They have experts come in, go into detail on each of the components for different arthritis. But importantly, they also have physiotherapists, occupational therapists, dietitians that are covered by the ministry. So it's not out of pocket for those with various kinds of arthritis. You don't need a referral to go to seek this out. You can self-refer if you just go on Google and Google Arthritis Society Canada. But you do need some sort of arthritis diagnosis before seeking care for them. But they've been excellent, and we hear great things about them from our patients. What GLAD Canada is based on the success of a program in Denmark. It's an education and exercise program for knee and hip arthritis that is 2 months long. Patients say great things about it. The studies show that it reduces pain, reduces medication use. There's less people taking sick leave from work because of these programs. People are more physically active. It's a great program. The one negative is it's not covered by the ministry. It's not covered by, so it's out of pocket, or if you have insurance for certain physiotherapy programs. But for those that can seek it out and have hip and knee arthritis, it's an excellent program. And then the bottom two are essentially patient organizations. Both Kappa and ACE are patient organizations that run seminars like this, that have resources online for those with arthritis to educate yourself how to manage symptoms, how to manage flares, what you can do at home, when to seek out care with a physician, and to be around a community of patients with arthritis to learn reliable information. So there's a lot of resources out there rather than just random Google searches that are reliable. And these are usually the ones that we recommend. At the end of the day, though, what I say as patients, there's no magic wand, unfortunately, with arthritis. There's no one medication. There's no one thing I can do to reverse the arthritis. Unfortunately, it's there for osteoarthritis specifically. But there is a treatment toolbox that we can use to help improve symptoms significantly, improve your function, and at the end of the day, prevent it from affecting other areas, or try to prevent you from progressing to surgery. Those that follow the recommendations do well. I can guarantee you that. And we see those patients. Most, unfortunately, do not follow the suggestions because it's difficult to do a lot of the physiotherapy, to do the weight-bearing exercises, to do the weight loss stuff. But those that do will notice an improvement and will prevent progression. And where we come in as healthcare providers is recommendations around the medications or the procedures, such as joint injections, can certainly help. So just in the last few minutes, you may say, okay, Dr. Koppikar, you talked about all this stuff, but what about all of this stuff that Dr. Google told me about that you haven't mentioned? So I'm going to just go over in the next few minutes a lot of the stuff that we hear about in our clinics that patients raise questions that may have come up in the chat. I'm not sure. I don't have access to the chat right now, but hopefully I can cover some of the common things that are out there that you've heard of. So the first thing that we get asked is, what about diet or an anti-inflammatory diet? So there's no such thing as an anti-inflammatory diet. It is marketed in that way to make money, to be honest with you, by certain people online, by companies to sell books, but there's no anti-inflammatory diet. Is there a link between diet and joint pain? I personally think there definitely is, and many patients notice it. But the reason I say there's no anti-inflammatory diet is that it's different in everyone. So recently, a Mediterranean diet has shown to help and helps with the heart as well. But what we suggest to people is as close to a Mediterranean diet you can get to if you want to focus on diet as a part of your treatment strategy, following Canada's food guide. But if you find that there are certain triggers, some people will say it's gluten, some people say it's this vegetable, some people will say it's this fruit, then eliminate that for a few weeks, just one by one, and see if it helps you. If you feel better, great, you can eliminate that. But if you don't feel better, then please go ahead and add it back, because there's no one solution fits all for everyone. In terms of natural medication, so you see glucosamine, chondroitin, a lot of things on the shelves at Walmart, Costco. So in terms of glucosamine and chondroitin, studies unfortunately did not show that it worked. The recommendations by guidelines and studies is by multiple studies, it's not just one study, is that it does not work and it's not recommended. It does not work in large populations, but some people do notice an improvement. So you could try it for a few months because it's relatively safe, as long as you check with your doctor and your pharmacist that there's no interaction with your other medications. If you feel better, continue. If after 3 to 6 months you don't feel better, just discontinue it and don't waste your money on it, because there's no evidence that actually helps the underlying process. What about turmeric? We use it in South Asian foods a lot in small quantities. Our issue with the ones marketed by pharmacies and companies is there's no studies to tell us what's the dose we should use. What does 550 milligrams mean? The problem is curcumin and turmeric have compounds similar to anti-inflammatories that can interact with other medications, especially blood thinners and heart medications. And we have seen, all of us have seen negative consequences of taking this with those other medications affecting the heart, the liver, causing bleeding. So be careful if you want to do it and make sure it's safe to use these medications. What about medical marijuana? So a lot more people are gravitating towards that. It's still very early. The studies are still going on. The evidence is not as definitive as some of the other stuff. But what we do notice is it can help with pain, can help with sleep and mood. The difference between CBD and recreational marijuana is that the medical marijuana doesn't have THC or doesn't have large quantities of THC. And that's the part that makes people high in recreational marijuana. So if you do want to go down this path, and some insurances do cover it, then check with a CBD clinic rather than over the counter, and just again make sure it's safe with other medications you take. What about chiropractors, massage, acupuncture? As long as you go to a reliable clinic and a reliable person, none of this will usually do any harm to the arthritis. Do it if you feel better, but make sure that you still focus on the strengthening exercises, as none of these are as helpful in the long run. You maybe feel better for 1 or 2 days, but you wanna make sure that you do the thing that has evidence, which is strengthening exercises, because that's what will help in the long run for symptoms and will help progression of disease. And lastly, a lot of clinics and a lot of doctors also, and online, you're seeing things like injections for viscosupplementation, platelet-rich plasma, stem cell injections. The bottom line with all of this is that there's no evidence that this works in osteoarthritis. It may work in other conditions. So I'm not saying that this is not good for other, like it has good evidence in some other things, both musculoskeletal and other medical issues. But in osteoarthritis, it has not worked. And the guidelines actually came out last year and said, we do not recommend it for osteoarthritis. Yet clinics offer it. It's expensive, very expensive. It's out of pocket. In most cases, some insurances cover it. But it makes the clinics a lot of money, if we were to be honest with you. But because there's no evidence, we don't recommend it first line. If you want to pay for it out of pocket or your insurance covers it, usually what we say is if you have exhausted other treatments that I've discussed, you've gone through everything and you don't want to head towards surgery, it may be worth a try. Or you can't use it because of other medical conditions like the medications we talked about, then it may be worth a try. So we do these injections even in our patients if they have paid for it and they bring it, but it's usually not something we recommend it, and it's not something certainly we sell ourselves. Patients buy it and bring it to us. But just as long as you're aware that nothing shows that it works in osteoarthritis, but if you want to spend for it and you feel better, then at the end of the day, that's your decision as well. So just those are some of the common things that come up in clinic and that we get asked all the time outside of the recommendations we make. When to seek out care with your doctor. Obviously, if you have joint pain and you've never been diagnosed, you should seek out care for an individualized treatment plan. But if you've been doing all this stuff and the joint swelling or pain is getting worse, certainly if you're noticing the joint is locking or giving away and looks like you're going to fall, you should seek out care because you may need more advanced imaging like MRI and maybe referral to a surgeon in that case. If the pain's getting worse, despite you trying the exercises and the medications, you may want to see them because maybe an injection is indicated or some other referrals are indicated. And then patients always ask us, when should I see this specialist? So family doctors are very competent at managing osteoarthritis and diagnosing it. If they're not comfortable because of the above reasons, they may refer to either sports medicine, physiatry, ourselves, or orthopedic surgeons based on the issue. But we usually manage immune arthritis. And what may indicate that is pain that is worse with rest, that gets better with movement. That's the opposite of osteoarthritis. Stiffness for more than an hour in the morning in those joints, severe swelling in many joints, or other symptoms such as rashes, ulcers that come on at the same time as joint pain suddenly, then that may suggest that there's something else going on. See your doctor. They know what tests to do initially. And if they're suspicious of an autoimmune arthritis or they need help differentiating it, then they will refer to a rheumatologist. And we will certainly, in that case, be happy to say, okay, this is still osteoarthritis or something else is going on, or redirect to another provider that can help more if we don't deal with it. So those are some reasons to see your doctor or a specialist. So that concludes the Whirlwind Tour. It's hard to kind of get everything into 25 minutes or so. So thank you. I'm happy to answer any questions at the end. These are just some of the resources, and we'll certainly send this out at the end of the presentation as well. And I would encourage anyone with arthritis to seek out these websites and these programs such as Arthritis Society. So thank you for having me, and hopefully that was helpful.
Thank you, Sahil, for that wonderful presentation and summarizing so much important and interesting information in such a short period. But you have done an excellent job. Thank you so very much. Our next presenter, Dr. Natasha Gakhal, is a graduate from Schulich's Medical School of Western Ontario University. She did her residency in internal medicine from Queen's University and in rheumatology at the University of Toronto. She is currently Assistant Professor of Medicine at University of Toronto, and her work at Women's College focuses on osteoporosis. In her presentation, she will cover diagnosis, prevention, and management of osteoporosis. Dr. Gakhal, over to you.
Thank you. Thank you for having me. I'm always happy to share and share my expertise and knowledge, particularly with our community. And I'm going to follow up and I'm going to talk about osteoporosis, and I'm going to spend a bit of time talking about how that's different from osteoarthritis, which Sahil talked about. So Sahil already gave our disclosures. The only other disclosure that I have is that I am a member of the Scientific Advisory Committee at Osteoporosis Canada. And like Sahil says, that these talks do not reflect the opinions or positions of Osteoporosis Canada, Women's College Hospital, or the University of Toronto. So these are the things I'm hoping I'll be able to convey over the course of this talk. Understand what osteoporosis is, understand what it's not, who's at risk for osteoporosis, how do we diagnose it, and how do we treat it. And very much like Sahil, the way I structured this talk was kind of addressing the questions that come up in clinic when I see a patient for the first time. So you're going to kind of get a mini snapshot of what questions get asked and how we address them in clinic. So what is osteoporosis? It's basically weak bones or low bone strength. And over time, you lose bone strength and mass. And that combination makes you at increased risk for broken bones. So on the right here, I have a picture of normal bone. And you can see that the bone is strong and the interconnections between each other is strong. And over time, osteoporosis, the bones get weaker and those connections or those networks also get weaker. And that combination is what makes people at risk for breaking bones. And so one of the big things in clinic I spend a lot of time talking to patients about is when they first come and see me, they want to tell me about all their pain. And I'm a rheumatologist just like Sahil, but when I do osteoporosis clinic, I don't actually want to address your joint pain, because osteoporosis, your risk of breaking a bone does not cause any pain. So it's not osteoarthritis. It's not joint pain. It's not stiffness. It's not swelling. The only way osteoporosis causes pain is if you have a broken bone. And you will know that. And really what can lead from a broken bone is it can cause reduced ability to do activities during in your day-to-day. You can have pain from the broken bone that can be long-lasting. You can have damage or disfigurement of the broken bone. So if you break your wrist, it may not heal exactly the way it was before, and so you might have some damage there. It can cause a loss of independence. If you fall and break your hip, you might need to use a cane for the rest of your life. And what I see a lot of in clinic, it lowers people's self-confidence and it causes a generalized fear in doing more activity. So if you have a broken bone, just to summarize, so you may not be able to be independent and functional. So you may not be able to walk without a gait aid. You may not be able to do your regular physical activity. So if you're used to running or playing tennis, if you sustain a broken bone, even long term, you may not be able to get back to the same level of physical activity you were doing before you broke the bone. Lots of patients worry about this. They come in saying, I remember my mother or my father having a hunched back. And this is what happens when we have broken bones in the back. It can also occur for other reasons, but when we do see what we call kyphosis, or the hunching of the back, we worry that there have been broken bones in the back, and that can cause pain and also your ability to look up straight as well. And then the worst possible thing is it can cause hospitalization, and particularly with hip broken bones, what I try to tell people in clinic is if you break your hip, the chances of you never getting back to your same level of functioning 1 year after is pretty high. And anybody who's had a mother or a father or a family member who's broken a hip, they all say, you don't need to tell me, Dr. Gakhal, I remember what happened to my mother or my father. They were never the same after they broke their hip. So what are the things that lead to not having strong bones in the first place? So some of the things are what we call non-modifiable, meaning like it is who you are and there's not much we can do about it. And then there are some things we can modify, some things we can change about our lifestyle. So for bone strength, majority of our bones are determined by our genetics. So we inherit the bones of our parents. Weight is a factor. Smaller people have a higher risk of having osteoporosis. Now, weight, if you're 5'1", your weight is your weight, and we can't change anything about that. Exercise plays a role. Smoking and alcohol. People who smoke and drink excessive amounts of alcohol have a greater chance of having lower bone strength. So those are things that we can do something about. And then age. So we can't stop aging, but we know as we age, osteoporosis is more common. There are certain medical conditions that can thin your bones. So autoimmune inflammatory diseases like rheumatoid, Crohn's, or ulcerative colitis, things that affect the stomach and your ability to absorb vitamins and keep weight on. And then there are certain medications that can also thin your bones. And in terms of medications, people always worry about this. And what I tell patients is, don't worry, your doctor knows which medications put you at risk for thinning your bones, and they will screen for that. There's few medications, there's not many that are known to be to affect bones. And so a lot of them are cortisone, but by mouth, not the inhalers, not the injections. A lot of the cancer treatments also will thin your bones. So osteoporosis is about broken bones, but it's actually not about all broken bones. So the most common broken bones we see are hips, back, wrist, and shoulder. But the other piece about broken bones is we want it to be from low trauma. So just to give you a few examples. So we are looking for broken bones that you sustain from a fall from standing height or less. So that's stuff like I tripped and fell over the curb, I tripped over my own feet or the rug. Slip and fall on ice counts as well. So it's where you started relative to the ground that we care about. Fall down the stairs isn't osteoporosis. So what I tell people is that I can't prevent broken bones from high trauma. So fall down the stairs is an example. Fall, anything in sports. So if you're riding a bicycle and you end up falling off of a riding bicycle, those aren't the type of broken bones that osteoporosis is looking at preventing. So how common is it? It's quite common, actually. So it'll affect 1 in 3 women and 1 in 5 men. And the 1 in 5 men we suspect is actually an undercall. We suspect we're missing a lot of men because they're just not being screened and picked up. And the important thing here is just to put it into a framework. So osteoporosis is actually more common than heart attack, stroke, and breast cancer combined. So it's quite prevalent. And majority of the broken bones we see in women specifically over the age of 50 are due to osteoporosis. So who is at risk for osteoporosis or broken bones? So age is a huge factor. So over 50, and that just increases with each decade. So 60-year-olds are more risk than 50-year-olds, 70-year-olds are at even more risk, and over 80, almost everybody is. And women more than men, as far as we know right now, although we think we are missing a lot of men. Genetics, like I said, a large part of your bones is what you inherited from your parents, and there's not much we can do about that. And then there's something we talk about in clinic, and we call it bone potential. Like, were you supposed to reach a certain level of bone strength, but you never got there for whatever reason? And I think we all know, I don't think people in their teens and early 20s are worried about their bones and making sure they get enough calcium and vitamin D and exercising. But say your parents had great bones, but you just never achieved the same. We say, well, you never really reached your genetic potential. And then on the right side is other things that put you at risk, and they're less frequent. And so we talked about medications, so steroids by mouth, cancer drugs like chemotherapy drugs put people at risk for thinning their bones, or diseases in rheumatology like rheumatoid arthritis, lupus, the stomach diseases. So if you're celiac or have Crohn's or ulcerative colitis, you probably should have at least a one-time look at your bones. If you have an overactive thyroid, so that's very uncommon. So that's not the common thyroid disease where you're taking thyroid replacement. It's you're making too much thyroid hormone and you actually need to take a medication to suppress it. People who have eating disorders, so anorexia and bulimia, and they're at risk because they have a low body weight. They're also not getting very much nutrition in, so they're at risk for osteoporosis. I mentioned before excessive smoking and alcohol. If you live a very sedentary lifestyle and don't do very much exercise, and then diet. We do have a few patients who just have very, very limited or poor diets, and that impacts their bones. So how do we diagnose it? And this, I also spend a lot of time in clinic talking about this. So if you remember only one thing from this talk, this is what I want you to remember. So this is the number one. So you have osteoporosis if you break a bone from low trauma. So if you fall from standing height and break your wrist, I already know you have osteoporosis. I don't actually need to do any test to figure that out. But what frequently patients talk to me about in clinic is, what did my bone density show? Do I have osteoporosis? And what I tell patients is, well, I already know you have osteoporosis because you broke a bone. The bone density is helping me in other ways, but I already know. And so the broken bone is like having a heart attack. So the heart attack tells me you already have a bad heart. I don't need to do your cholesterol or check your blood pressure to tell me you have a bad heart. I already know you have a bad heart. We're going to check the cholesterol and the blood pressure, just like the bone density, to help us improve your risk, but I don't need to do it to show that you have a bad heart. So if you have the event that we're trying to prevent, you have the diagnosis. Now, hopefully when you come to clinic, you haven't had a broken bone. So if you haven't had a broken bone, then the bone density is my next best test to figure out how bad your bones are. So just if any of you haven't had a bone mineral density test, this is what it looks like. So you're lying on a table for 15 to 20 minutes while a small X-ray detector is scanning your hip and your spine, and sometimes your arm if we need another site. So the X-ray is actually on top, and it's going to be moving up and down, and then you have the technician at the computer making sure the images are coming out appropriately. You might have to lift your legs, which is hard for some people, as well as straighten your back. It's safe, it's painless, it doesn't involve any injection. People worry about radiation. It's actually a very, very small amount of radiation as far as an X-ray test goes. It's the equivalent of flying from Toronto to Vancouver. So who should get a test for osteoporosis? So if you've never broken a bone, or if you have broken a bone, you should probably get a test. And so we do see a large number of people who come in that way. I slipped and fell on the ice this past winter. I broke my wrist, and my family doctor is going to send me for a bone mineral density test. But if you're lucky enough not to have broken a bone, then what do the guidelines say? So we have Canadian guidelines that say everybody over the age of 65, male or female, should get at least a one-time bone density test at that age. So if you get to 65 and you haven't broken a bone and you don't have any diseases or are on any medications that thin your bone, you should get a bone density test. Between 50 and 64 years old, you can get a bone density test in certain situations. And if you're in this age range, I would talk to your family doctor and see if you qualify for a bone density in this age. Not everybody in this age needs a bone density, only certain individuals. And then we really don't recommend it in people under 50, unless you have a medical disease that impacts your bones. So if you are 40 years old and end up getting breast cancer and end up going on medication that thins your bone, you deserve to have a bone density under the age of 50. Or if you start having broken bones for low trauma. So if you're, once again, 40 years old and you slip and fall, you break your wrist, you should probably get your bones checked out, because for the most part, younger people don't tend to break bones that easily. If you have osteoporosis or at risk. And so I put the treatments into two categories. The first treatment is for all. That's calcium, vitamin D, and exercise. And then the second arm is medications, which is for some, but not all. And I'll go through each of these. So calcium. There's a lot of confusion in clinic about the vitamins. So hopefully I'll be able to clarify some things here. So the goal is to aim for 1,000 to 1,200 milligrams a day of elemental calcium. It's better if you get it from diet. It's more bioavailable. If you need a supplement, though, to get you to that 1,000, which a lot of us do as we get older. So my experience in clinic is that you either have people who love dairy and they can easily get it, through diet. And then you have the rest of us who are getting a little bit, but probably not reaching the target. But the key here is you cannot take a calcium pill to supplement the whole amount. So you should not be taking 1,000 to 1,200 milligrams a day of a pill. This recommendation is lower than what it was 10 years ago. We used to say 1,500 and now we've downgraded to 1,200. And most of us say if you're getting 1,000 or more, you're probably okay. Vitamin D, it's called the sunshine vitamin. So we actually can get it from the sun. However, we don't actually get enough from the sun for several different reasons. So one is as we get older, like many things, our skin isn't as good as converting it from the sun to the active form of vitamin D. The darker skinned you are, it just won't absorb as well. And then if you live in cold climates like Canada, we just don't see enough sun exposure to get enough vitamin D from the sun. The other thing is we don't get enough vitamin D in our food. It's not the one vitamin that's heavily fortified in food. So eating a well-balanced diet still probably won't get you enough vitamin D. Aim is for 1,000 to 2,000 international units a day of vitamin D3. And a couple of things I want to make here is to really read your labels carefully. So, people worry about their prescription drugs all the time, but then can't tell me anything about the vitamins they're taking, what the doses they're taking are. So really, make sure you know how much you're taking. And the dosing can be confusing. You do actually sometimes have to do quite a bit of math. And if you end up taking a supplement where it's multiple pills to get to the amount, it's even more confusing. And if you're confused, just bring your bottles with you. I actually prefer that when people come in, instead of them guessing or us guessing how much they're taking, just bring the bottle in and we'll figure it out together. People love combination pills, so combination calcium and vitamin D, and it makes sense. I can take one pill and get 2 vitamins. However, most combination pills will not give you enough of one thing and give you too much of another. So the most common combination pill, Caltrate, I find gives you enough calcium, so it gives you that 500, 600 of calcium that you need, but it's probably not going to give you enough. It's not going to get you that 1,000 of vitamin D. So I actually do, for the most part, tell people it's probably better to separate them out so you actually get the appropriate amounts. And do not base it on brand. People want to tell me that they're taking this amazing, expensive calcium or vitamin D. And I kind of say, if you did a survey of the doctors and the allied health, the physios and the nurses in our clinic of what brands of calcium and vitamin D we're taking, we're all taking the generic, whatever brand, Life brand, Kirkland brand, whatever it is, because the brand doesn't matter. So be very careful about spending a lot of money because it doesn't really make a difference. So calcium in foods, people really want to know this information. It's confusing. A lot of the information on the internet around diet and nutrition, like Sahil said, is very confusing, and it's unclear how accurate it is. So we encourage people to get 1,000 to 1,200 milligrams of calcium from all sources combined, ideally diet. So here is a graph of some of the things that have calcium in it. And the amount. So there are lots of non-dairy foods that have calcium. But what I try to emphasize to people is you got to look at the bang for your buck. So yes, leafy greens, nuts have calcium in them. But if you take, for example, 1 cup of kale only gives you 100 milligrams, where an inch firm cube of cheese will give you 1/3 of your daily serving. So you've got to think about volume, right? Or people say they have almonds every day. Well, for instance, 20 almonds will get you 100 milligrams. So you have to eat a lot of almonds to get to the equivalent of a glass of milk. And we don't advocate that you eat that many almonds. So really, dairy is the highest value food because you can eat a little bit of it, but get lots of calcium out of it. So I tell patients 1 inch firm cube of cheese, 3/4 cups of yogurt, 1 glass, so 8-ounce glass of milk or alternative. So cow's milk, all the alternative milk beverages have the same amount of milk as well as fortified orange juice. And I've turned all the cartons for the alternative milk beverages over in the grocery store. When I first started, they have the equivalent. So if you drink soy milk or almond milk, it's the equivalent of 1 glass of cow's milk. The problem with dairy is as we get older, it's a little bit harder to digest. A lot of us don't tolerate it very well. So that's the first thing. And then lots of people tell me, well, with cheese, they have a cholesterol problem and they've been asked to kind of limit their fats in their diet. So it is a bit of a struggle sometimes to get 3 servings of dairy in, and that's why we do look to these alternative sources as well. So the one thing that doesn't get talked about a lot is protein. So protein is actually really important because it gives our bones strength and flexibility. And it's a component of muscle, and it helps us to move and to prevent falls. And we know that as we get older, we're just not getting enough protein. And so, you know, protein, obviously, we know we get it from meats, but there are also other very good sources of protein. Nuts, lentils, eggs, milk are all very good sources of protein as well. And there's a lot more research coming out that protein is, we're probably forgetting about protein, and it's so important as we get older. These are the vitamins that I hear a lot about in clinic that really don't have any strong evidence. So strontium, magnesium, and vitamin K. And I'm not going to spend a lot of time on it, but people want to tell me, oh, I'm taking my calcium with magnesium. I'm taking a vitamin K. And I'm like, if you want to take it, there's no evidence that it does anything for bone. As long as, you know, and like Sahil said, some of these things have side effects or interactions with other medications, so you have to be careful. But when it comes specifically for bone health, we don't recommend that patients take these things for bone health currently. Exercise. So, you know, I'm going to spend a couple minutes on exercise because I think there's a lot of misconceptions about exercise. So these are the comments that I hear in clinic. I hear weight-bearing exercise is really important, Dr. Gakhal. So, and then they say, I walk a lot. And that's true, weight-bearing exercise, walking is a weight-bearing exercise. And then they also think that lifting free weights is a weight-bearing exercise. So I'm going to talk a little bit about how it's not really that or just that, it's more than that. And then there's this other comment that I get a lot in clinic, which is I hear exercise can improve or reverse my osteoporosis or bone density results. And I'm going to talk a little bit about that. So exercise, the number one reason to recommend exercise for osteoporosis is to prevent falls. That is the number one reason. But it also can build muscle strength and flexibility and protect your spine, both which can lead to preventing falls. And then we're not quite sure it slows bone loss. There might be a small study to show that it does have a little bit of impact on bone density, but that's not the major driver for exercise. So pretty much, even though people talk about weight-bearing exercise for osteoporosis, all exercise is important. And I find that balance and flexibility exercises are forgotten. So here we should be doing balance exercises every day and posture awareness exercises every day. And I'll talk about what those are. Strength training at least twice a week. And we should actually be doing cardio or aerobic physical activity most days of the week. So this is from Osteoporosis Canada. So strength training exercises, so that's, you know, so the comments in clinic I say, oh, I lift free weights, Dr. Gakhal. Well, that's not really what we're talking about. We're talking about kind of resistance strength training. So things like squats, wall push-ups, taking an elastic band and doing like row exercises, and then step exercises using a step device. Balance exercises. So if you want to make it a bit more fun, things like Tai Chi, dancing are actually excellent for balance. And all my patients, after they've seen our occupational therapist, they're like, yes, I periodically stand on one foot in the kitchen while I'm doing my cooking just to practice. So that's a very common and easy balance exercises. Make sure you support yourself. and shifting your weight from your heels to your toes while you're standing also builds in that balance piece. Posture awareness, and I'm terrible at this. So posture is you have to think about it to do it properly every day. And so really you need to tuck your chin in and lift up your chest. And my physio says your ears have to be aligned with your shoulders. So if you have that, then you have good posture. You can also try standing against a wall, putting your back against the wall or a door, and trying to get your head back to the door, and that's the appropriate posture you should have. And then physical activity. So that's walking, dancing, jogging, aerobics classes. And the key here is 150 minutes a week sounds really overwhelming, but it can be in bursts of 10 to 15 minutes. And, everybody is walking, but it's got to be a pretty brisk walk. So you can talk while you're walking, but you shouldn't be able to sing. So when you're talking, you should feel a little bit out of breath, and that's a good pace of walking. We talk about spine, protecting the spine. So what does that mean? That's basically knowing how to bend. So we're not bending with our back. We're bending our knees and hips to lift items. We're using a stool to tie our shoes. We're not twisting with our spine. We're turning our whole body. So those are kind of learned behaviors that we have to do over time. And then medications. I'm not going to spend a lot of time on medications because everybody is an individual, but the goal of medication that I wanted to emphasize is to reduce your risk of breaking a bone. And the second one is, and less so, is to prevent bone loss, which is measured by the bone density test. So I have a lot of patients in clinic saying, Dr. Gakhal, I was on a bone medication and it never did anything for my bone density. But the goal of medication when it comes to your bone density is to keep it stable. Most of the bone medication won't increase your bone density, it'll keep it stable. So it is a win. So I tell people, if you're on medication and you have a stable bone density and you haven't broken a bone, that's a success. There are, however, a few medications that can actually improve your bone density, and your doctor will know about which ones. And so just very briefly, I'm not going to go over these medications, but the first line medications are still what we call the bisphosphonates. So you've probably heard of some of these. I've put the brand name in brackets there. A lot of people now are on denosumab or Prolia, and it's typically after the first line medications, but some people will go on it first. And then the ones on the right-hand side are really reserved for the most severe osteoporosis, people who have failed other medications, or there are special cases. So most people will live in the first or second category if they need medication. I just want to highlight three things about these medications. Once again, things that I hear in clinic. They're safe, but they've gotten a lot of press over the past 10, 15 years for a couple of reasons. So most patients go in and saying, oh, Dr. Gakhal, I want to avoid those medications. I hear they're horrible. They can cause jaw issues and brittle bones. So the jaw issue is that in very, very rare circumstances, it can cause a loss of blood supply to an area of the jawbone, and that area of the jawbone can die. It's a terrible side effect, but what I tell people is it's 1 in 10,000 patient years. So if I took every year a patient was on that drug and got 10,000 years, we'd have one case. The brittle bone effect comes from the fact that about 15 years ago, we started to notice that people who were on these drugs for more than 5 years started to get micro cracks of the thigh bone. But that is also incredibly rare. So once again, anywhere from 3 to 50 cases for 100,000 years of treated years. So very, very rare. And both these side effects. So if the doctor is saying you would benefit from the medication, the benefit outweighs these small risks. And then the other thing I have to tell patients is these drugs, if you're going to take them, you need to use them for a few years at least to see any benefit. There's no value in going on these drugs for 6 months, 12 months, and even some people would say a couple of years. So I usually, when I put people on, I say, it's at least 3 years, maybe even longer. So just to summarize, so what is osteoporosis? It's your risk of breaking a bone. That's what we're trying to figure out. How likely are you to break a bone? And we typically put it in 10-year kind of batches. So when I see you in clinic, I'm trying to figure out what your risk of breaking a bone is in the next 10 years. And remember, there's no symptoms. What osteoporosis is not is pain. So it's not about your joint pain. It's not about your knee pain. It's not about your hip pain. It's not about your hand pain. Who's at risk for osteoporosis? Well, we talked about that there's lots of risk factors, but age is the biggest one. So as we get older, your risk is quite high, and over 80, almost everybody is has it or is at risk for it. And the diagnosis comes from breaking a bone with low or no trauma, and then a bone density test. And calcium and vitamin D and exercise should be for everybody. And I typically tell people, even if you don't have osteoporosis, these things aren't bad. And then in select individuals, medications may be needed. And if you want more information, I recommend going to Osteoporosis Canada. Very good resources for diet and exercise that are very easy to read and follow, and they have great videos. Thank you.
Thank you, Dr. Gakhal. That's for that wonderful presentation full of information. I know that most of us are quite familiar with arthritis and maybe one broken bone, but few have heard osteoporosis. You have shed beautiful light on it. Thank you so much. Both arthritis and osteoporosis are such heavy subjects. It's impossible to make justice in 20-25 minutes, but both Dr. Koppikar and Dr. Gakhal has done a marvelous job. Thank you very much. I'm sure that there are a few questions. At this point, I'd like to request Anjana Pai to handle the Q&A session, please.
Sure. Thank you, Sadanand ma'am. Thank you, Dr. Koppikar and Dr. Gakhal. So there are a few questions in Zoom. So the first one is probably for Dr. Koppikar because it came earlier in the session. So many people suggest just to go for surgery instead of other treatments. What is your advice on that?
So it's hard to kind of give a blanket statement. Probably the most people we would say no, that you should try the other therapies because some of them can prevent progression to surgery, but it also depends on what life stage and kind of how severe the arthritis is. The two reasons not to jump to surgery, one, if you're younger and even like 50s, 60s, 70s, the joints, they're lasting longer, the joint replacements, but they may not last your entire lifetime. So if they need to redo it in your 80s or 90s, there's more problem with that. So that's something to speak to the surgeon about, how long they think the metal will last and whether it will last your whole life or if they have to go back in. So even the surgeons like to push it. And in fact, most people we send to them, they will not operate. And they'll say, try some of the other stuff first, and then only really when you need it will they offer it. If a surgeon is offering it, it's probably severe enough that they think that you should go for surgery. But I'd be careful when other people say, oh, just jump to surgery, it didn't work. It may be because others didn't optimize or weren't given the advice about all the other stuff before surgery, because one of the goals is to try to avoid it if you can.
Great. Thank you. Thank you, doctor. So the next question is, what about some foods that induce more inflammation? I think you were talking about some foods people think might help, but not necessarily true, depending on the person's makeup and other conditions. But what about some foods that can induce more inflammation? Anything to be avoided?
Yeah, and this is being studied, and we're studying it at Women's, and a lot of debate about this. So I think because it's very different for everyone, it's what I tell patients is it's different. So you have to identify what may trigger more pain in you. The common things I hear, and Natasha can jump in here if she has other advice, but the common things I hear from patients is Often they'll find certain like processed foods, sugars will trigger more of their pain. Nightshade vegetables will trigger not the entire class, but certain things. Some patients will say, oh, it's every time I have tomatoes, my arthritis flares. I see that link more with the immune arthritis, with like rheumatoid arthritis or lupus, or the ones we deal with, than osteoarthritis. But in general, processed foods, sugars, nightshade vegetables. Some people find a lot of gluten can trigger more pain. I'm not certainly recommending that you avoid all of those because they're part of a healthy diet, but it goes back to, if you identify one particular thing, eliminate it for 2 weeks, see what happens. If you feel a lot better, then maybe it was. So I'm a proponent that there is a link between diet, inflammation, and joint pain. I know there's a lot of debate in medicine. I don't think there's one anti-inflammatory diet we can give, is the advice. I don't know if Dr. Gakhal has anything about diet to add. We may differ on our opinions.
Yeah, I think we don't know. I think what I tell patients is, I think highly processed foods just in general don't feel great in our body, and our diets are highly processed. So even if you eat at home, a lot of us are doing half-made homemade, right? So it's not like when, we were little or from back home where everything was from scratch, right? We're not doing that anymore. So I just think, when I have a bowl of pasta, yeah, an hour later, I may not feel great either. And that's not linked to joint pain. It's just processed food in general. And as we get older, processed food, as we all know, feels less good to us, right? So I think there is a link, but I'm not sure it's the link we think it is.
Thank you, doctors. So the next question was for CBD oil, but I think Dr. Koppikar addressed it in his presentation, so we'll skip it in the interest of time. So the next question is stiffness while sitting cross-legged. Is it same as OA? I guess they mean osteoarthritis.
Yeah, so that's a good question. So it could be a symptom of osteoarthritis. The problem with stiffness is, so it's one symptom. We don't use one symptom to make the diagnosis, so your doctor will ask other questions. So the short answer is yes, it could be a symptom if it's short lasting, or if it's stiffness while you're sitting there in 5-10 minutes after you start walking. But if you're certainly noticing stiffness for prolonged periods, for 30-45 minutes or longer after periods of rest, you're noticing one knee is significantly bigger than the other with swelling, then I would seek out care with your provider, because that may suggest some other diagnoses. But several minutes of stiffness after could certainly be a symptom of osteoarthritis. I think you're muted, Anjana.
Yes, sorry. Do you have a link for the exercises and strengthening for knee?
Yeah, I'll send it to Sanamam after, so you can send it out with the presentation.
Excellent. Thank you so much. So the next question says, can someone without osteoporosis take calcium and vitamin D?
Yeah, so currently there is no recommendation for people not with osteoporosis or at risk for osteoporosis, but like I said, it wouldn't hurt, right? So I take a vitamin D and I don't, I've never been tested for osteoporosis. I'm not yet there yet, but I take a vitamin D just because I know most Canadians were deficient, right? So just to give you guys an example, 70, the vitamin D level, in the labs is 70. Most Canadians are in the 50 range because we live in darkness for 6 months out of the year. And the darker skin you are, the lower that number is. So we're gonna have lower numbers than 50 than compared to Caucasians. So it doesn't hurt. What I would say though is don't overdose on it. So I've got people taking 5, 6, 10,000 of vitamin D, once again, because they heard it was good for so many things. It's not, there's nothing to support it. So, but if you take 1,000 a day, it's very safe. And I tell people it couldn't hurt. And don't know if it'll help, but from a side effect point of view, it's fine.
I think the next one is more of a comment. They're saying, being lactose intolerant, I think I should take calcium. No osteoporosis. I do take vitamin D3 and lactose-free milk. I think it's more of a comment. I think it's fine based on what you said, doctor. So is there any negative impact of taking calcium and vitamin D3 supplements regularly in the long run?
So vitamin D, no. Once again, stay in the dose range though, right? So the number one thing I see is people are overdosing on vitamin D because they're like, well, what's the harm? And you can get vitamin D toxicity, right? So there is no reason. We sometimes will put people up to 4,000 or 5,000 if they're very, very low, but nobody needs to stay at 5,000 of vitamin D daily. And I'll tell you, the only people who need to do that is people who have gut problems. And I'm not talking about irritable bowel. I'm talking about my patients who had their stomach removed for surgery, right? They might need higher doses just because they can't absorb it. Calcium is a little bit more muddled and confusing because there was studies out 10, 15 years ago saying that calcium supplements may not be so good for the heart, that if you took them, they would cause an increased risk of heart attack and stroke. That study, for the most part, most of us agree is not a good study and wasn't done well. And we've never been able to see that effect again. But that's what really triggered us to say, okay, let's reduce what we're telling people to take. 600 is the maximum from a pill. And if you have history of kidney stones, you probably want to talk to your doctor. And what I want to emphasize is that these are threshold vitamins. Once you get enough, it's enough. Getting extra doesn't make your bones any stronger, okay? So taking 2 calcium pills is not going to make your bones more strong than taking 1.
The next question, are tendinitis and bursitis the side effects of Evenity, and how can I treat it?
Yeah, so Evenity is really is a newer bone medication on the market just before COVID, about 3-4 years old. Joint pain is one of the side effects listed on Evenity. So I would say before you attribute it to the medication, talk to your doctor, get checked out. Tendinitis and bursitis are very common as we get older, just in general. So before you attribute it to the medication, just see if there's another cause for it. The beauty of Evenity is it's only for a year. So if you can kind of, if you're really convinced it's from the Evenity, I would say you only have to, the medication's only for a year. So just stick with it.
The next question, what is your opinion of Ayurvedic medicines for osteoporosis? Should they be taken if you're already on medication like Prolia? Dr. Gakhal, you're on mute.
Yeah, sorry. And I'll see if Sahil has any thoughts about this, because we hear this both for osteoporosis and osteoarthritis as well. I think the answer is we don't know. I think, with a lot of supplements and homeopathic or natural therapies, we just don't know. And we don't know what we're getting in the medicines, and we don't know the interactions. Both me and Sahil have had cases where people have been taking natural supplements and we've had like side effects of like liver and stuff like that. Short answer is don't know. The honest answer is lots of people are probably taking them anyways, right? So tell your doctor. But the evidence is, even when my patients tell me, I'm like, I don't really know the answer to that because there's no studies to look at that. I don't know, Sahil, if you have anything to add to that.
No, that's exactly. I think we all say that because we don't know. It doesn't mean that we're against it or if it's bad. The problem is they don't have to go through regulated studies, so we don't know what dose, what they're mixing it with. They may say what they're packaging, and those things, especially if you're on other, like the people we've had side effects with, they have either other medications, blood thinners, heart disease, and that interaction can affect organs, and we've seen serious issues from that. So if you are taking something, one thing I say is see if there's different components like ingredients, and you can take that to a pharmacist who can check for interactions. If them and your doctor are comfortable that there's no serious interactions, then you could try it. So it's not that we're against, just be safe. There's a lot of marketing strategies and money-making schemes out of this as well.
Anjana, this is Sadanand. There is only a minute left in the scheduled time. If there are too many questions and are ready for about 5-10 minutes, we can just extend it. Is it okay, Sahil and Natasha, about 10 minutes?
I'm fine. Natasha, I
I
can.
think we only have 3 more questions here.
Okay,
that's
good.
how-
That's
yeah.
great. Go ahead.
Yeah. So let's continue then. Any specific brand of vitamin D and C you can recommend?
No, so like I said in my presentation, no, don't spend a lot of money on this. Okay, so if it was me, and like I said, ask every doctor in my clinic, ask the nurses, the physiotherapists, what are we going for when we go for calcium and vitamin D? We're going for the generic brands, right? Because they're cheaper and they're the same. So people tell me I'm taking a really good one. It's really expensive. And I'm like, cost has nothing to do with it. Sometimes, people prefer certain brands because it feels like it's easier for them to take. That's different, though, of how well the actual vitamin or supplement works.
Okay. Is there any merit to taking an Ayurvedic medicine called Re-Osto from Himalaya Lab? I think you kind of answered this already, so I don't know if you have anything to add. No? Okay, so we can move on to the next one. Is bursitis best treated by an orthopedic surgeon or a rheumatologist?
I can handle that. So I think that was second to the Avinity question, but essentially, so orthopedics for sure won't, they're really focused on is anything surgical or non-surgical. They don't deal with anything medical. So they're answering one question, am I replacing your joint or not? And then they'll go ahead and do that. So there's a lot of musculoskeletal specialists, just to clarify, because even doctors get confused. So in terms of medical management of musculoskeletal specialists, there's us as rheumatologists that deal with a lot of, the bulk of our stuff is autoimmune arthritis, where the immune system targets the joint, the organs, causing inflammation. So rheumatoid arthritis, lupus. There's sports medicine, deal with regional musculoskeletal pain. So those are specialists that deal with things like bursitis, tendonitis. It doesn't mean we don't see that. We can certainly do injections, we can see them, but that's their area. And you can self-refer to them, or you can get referred by your doctor. Sports medicine is a great area to start off for bursitis with, because they have local ultrasound in their clinics. They work with the physiotherapists and they can do injections as needed. And if it's more complex musculoskeletal non-immune system problem, there's a specialty called physiatry, which no one's almost never heard of. I hadn't heard of before med school. They're called physical medicine and rehabilitation. So these are 5-year specialists that deal with mechanical, structural musculoskeletal issues, a lot of them that are not driven by the immune system. So they're kind of the flip side of us. So they're around as well for regional, what we call regional pain, for like bursitis, tendonitis, and they're really good with procedures and stuff as well. So coming back around, so your family doctor will know who to refer to if they're not comfortable managing it. So bursitis is probably best dealt by sports medicine and or physiatry. That's not physiotherapy, that's the physiatrists at MDs who deal with it. We do as well. So based on where you live, and a lot of times you may not have access to physiatry or sports medicine, then rheumatology certainly can do the procedures as well, if based on if they're open and not filled with immune arthritis.
Is skipping rope good for your bones?
Sorry, I missed the question.
Is skipping rope good for your bones?
Skipping rope. Skipping rope.
Yes.
Yes. Well, yes, because it's weight bearing and it's aerobic. So that's actually a great, I've never gotten that one before, but that is an excellent exercise. And I would say balance as well, right? So that I agree. I think that would be a great exercise.
Also high risk for falls, so be careful.
Balance, I guess, again. Use it with caution. Next question. What is the best way to prevent gout? Can gout prevention in mid-30s be achieved through lifestyle changes? So there's sort of 2 parts. What is the best way to prevent gout? And can gout prevention in mid-30s be achieved through lifestyle changes?
Yeah, so that's a good question. We get that a lot too, and Natasha can add to it. But basically, gout's a bit more complex than we historically used to say it was only diet. So we do realize there's a genetic component to driving gout, your ability to clear things like uric acid, which triggers gout, especially if you get it at a young age, like 30, 40, then probably a genetic component to it, certainly. Diet certainly can trigger flares. So that's things like purine, so red meats, veggies that are high in purine, alcohol. I can certainly trigger it. But if you're having multiple flares, there is a genetic component. There may be ways to prevent it from coming on regularly with medications by clearing uric acid. So if you're certainly having more than 2-3 flares a year, you should talk to your doctor about that, because recurrent gout flares are also not good for the joint. They can damage the joint. And there's some studies coming out saying that high uric acid levels associated with kidney disease and heart disease as well. So if it's one flare every few years, diet control is fine, and Google search should show you which diets to avoid. But if it's recurrent, you should certainly speak to your doctor, because that may need further therapies.
Thank you, Dr. Koppikar. We come to the end of the questions and that we have so far. If there are any further questions, you can always send them later, and Sadanand Ma'am will try his best to get the answers from both the doctors. So Sadanand Ma'am, back to you.
Thank you, Anjana. Thank you for handling that question and answer session. And again, thank you, Dr. Koppikar and Dr. Gakhal, for the fantastic presentations. I know that audience will be very much interested in seeing the presentations, etc. I must mention that since the beginning of the Ontario OCA Seniors Forum in 2016, we had held over 45 seminars, workshops, etc. And that was possible only because of the strong and continued support from Ontario Konkani Association and Sringeri Vidya Bharati Foundation. I'm so glad that Dr. Param Bhatt, the trustee of SVBF, is here. Over to you, Param.
Thank you very much, Sadanand. First of all, very much thank Dr. Koppikar and Dr. Gakhal. I think probably I got information which I could not have got even after 10 visits to my doctor. It was $1 million worth of information that you two have provided us. So I'm extremely grateful for the two doctors who took the time off today to talk to us. So hope to follow up, Sadanand, and this is a very important topic for many of us who are the older aging population here. So, and I also want to thank very much Sadanand and OCA for organizing these seminars. So these are very useful, and I'm sure many people enjoy listening to these informative sessions. Special thanks to Rachana Kamath and Anjana Pai for managing today's program. And once again, OCA, thanks very much for being a partner with the SVBF.
Thank you, Param. It's really, really, really appreciate. And you know how much we appreciate your support, without which we couldn't have done any of these workshops. Anjana, President of OCA, do you have any comments?
Yeah, I'll just take a minute. Hello, everyone. For those of you who don't know me, I'm Anjana Pai with my husband, Praveen Pai. I'm the president of Ontario Konkani Association this year. So I want to thank Dr. Koppikar and Dr. Gakhal. Can't thank them enough for taking time from their busy schedule to come and provide us this very informative session today, for answering all the questions. Thanks to SVBF, Paramji, and Sadanand Ma'am for always organizing these very valuable virtual health sessions for the benefit of not only Konkani community, but also all our family and extended family and friends. Last but not the least, to our very engaging audience for patiently, staying online, joining us from YouTube, Zoom. Together, I think we had about 50 plus around 65 participants from different parts. So thank you for being an engaging audience and listening and asking great questions for the benefit of the rest of us. So thank you very much, everyone. Thank you, Rachana, for setting up the Zoom, for YouTube, and for making sure everything goes smoothly without a glitch. Thank you, everyone. I hope I have not missed anyone.
Yeah, thank you, Anjana. As both of you said, especially for a tech illiterate like me, tech savvy Rachana's help is just godsend. Thank you, Rachana. Thank you, everyone. Until we see next time, we will be having some other sessions. And I know that in June, there will be an extraordinary event, which we will share the information as time passes. Once again, thank you all. Have a great Sunday and a highly productive week ahead of you. Bye now.
When